My task is to try and provide some of the highlights from AASLD meeting that was held in Boston. As some of you may not have attended the meeting, or most may not have attended the meeting, so I'll try and update you on what was presented at the meeting that was of some importance. Again, this is my disclosure. All right, if you were to look at CDC annual progress report and look at 2020 goals, disappointingly, in the United States, we're not doing well with regard to new HCV cases. The expectation was to reduce acute Hep C cases to 0.25 per 100,000 population, but as of 2007, the rate was around 1.07 per 100,000 population. What we've seen is, though, a decrease in mortality due to HCV related liver disease, and that's, of course, encouraging. But we need to work on acute infections and try and prevent the number of acute infections in the U.S. So I will go over some select abstracts and talk about global elimination and challenges with access to care. Now, a model country has been Iceland, among other countries, where they are on track towards global elimination of hepatitis C. They have a program called TRAP Hep C program, and this provides wide access to treatment in Iceland and to achieve the WHO treatment coverage targets of 90% diagnosis and 80% treatment of eligible patients by 2030. They've had this program in place for about 3 years thus far, and there's been an exponential increase in the number of testings for hepatitis C. It's been up to 81% in 2018 compared to 2016. And they've had a good success with treatment. They had 95% SVR in these patients who were identified and treated. So the conclusion was that during the first 3 years of TRAP Hep C program, over 95% of eligible patients in Ireland were initiated on DAs, thus surpassing the WHO treatment target. Now, in the U.S., the linkage to care has been a challenge, apart from identifying those with infection. And this is a small observation made from 3 emergency departments in Seattle. And the study was such that they were trying to see if they can link them to care. And what they screened about 2,400 odd individuals who visited emergency room, and broke them down by age greater than 40 and ages less than or equal to 40, and identified a certain number of patients who had hepatitis C infection. But then, if you were to look at the bottom here, if you were to look at linkage to care, and those who started treatment, it's really not impressive. And then particularly in those less than or equal to 40 years of age, very few started treatment. And this suggests that it's feasible, but was not a robust experience where most were linked to care, and particularly the younger population, the failure to link them to care was rather high. So we do have challenges, in the U.S. in that we do have a population that is challenging, and that they fall in the category of injection drug use or other substance abuse, where healthcare seeking behavior is rather poor. So then another study looked at linking pregnant women with hepatitis C infection to care after delivery. This was in a high-risk population, as you can see here. About 40% had, actually 40% had substance abuse during pregnancy. You look at history of injection drug use, about 80% had history of injection drug use. And then, so they identified 97 pregnant women. As you can see, most of them were unmarried. They had Medicaid insurance, which is insurance provided by the state, and then a fair number of them had used drugs. And so they attempted to link them to care, and they suggested that they could be linked, but the follow-up was rather suboptimal in these patients in terms of going for care. And in this high-risk population in Kentucky, they really had multiple factors that would suggest that this population might be challenging to get them to care. Now, this is a study from India where they looked at decentralized care for chronic hepatitis C for persons who injected drugs. And they use all generic direct-acting antivirals. And they looked at a particular form of treatment. They basically trained primary care physicians from 3 university centers and 22 district hospitals. They had a good number of individuals who had a history of injection drug use in the background, and about 7% had compensated cirrhosis. About 66% completed 12 weeks follow-up, and they for SVR12. And there are quite a few treatment interruptions, and patients some had not completed treatment. Overall, though, the SVR rate was 92%, but then if you were to look at intention to treat population or outcome, it was 51%. And then, they concluded that patients who have a background of injection drug use with hepatitis C, they can be treated by primary care physicians in a decentralized manner. And there was a fact to it, but I tell you, looking at this data, I find it challenging that this population may not do well in such an environment, particularly if they're likely to have interruptions. And a fair number of them had interruptions as well. Nevertheless, I think this is one attempt to see if they could decentralize hepatitis C care, given that it's hard to treat all of these patients in a tertiary center. Now, what about acute infection and reinfection? This is one study that looked at sofosbuvir and velpatasvir for 6 weeks and 12 weeks in those who had recently acquired hepatitis C infection. This is acute infection. And in those who were treated for 6 weeks, the SVR rate was 79%. Those who were treated for 12 weeks was 95%. And if we were to look at patients with virologic relapse, these were some patients who had either had primary infection or some had reinfection, and they relapsed after 6 weeks of treatment primarily. And so in essence, they concluded from this study that 6 weeks of sofosbuvir and velpatasvir was inferior to 12 weeks of treatment in those with acute hepatitis C infection. Something we need to keep in mind, ultra-short course may not work in these patients. What about reinfection? This is a Canadian study that looked at reinfection. These are about 5,700 patients who received DAA treatment. These are patients who were followed, and there were 62 reinfections during 4,835 person-years of follow-up post-SVR. And the reinfection rate was higher among persons with injection drug use history than those with non-PWID history. And then this was more common among those who were born after 1975. What is interesting is that there were no reinfections among PWID population who received uninterrupted opioid agonist therapy. The conclusion was that the reinfection rate is relatively low, and there was a reinfection, it was highest among younger men, and the reinfection rate was low in those with continuous opioid agonist therapy. Now, what about vaccine? There was one study that was presented on hepatitis C vaccine in an at-risk population. It was a randomized, double-blind, placebo-controlled trial. 455 HCV uninfected individuals between the ages of 18 and 45 at risk due to active injection drug use were enrolled. So randomization was 1-to-1. About 78% of vaccinated individuals generated T-cell response. It was well tolerated. There were more injection site reactions after vaccine injection, but there were no serious vaccine-related AEs. But then, if we were to look at incidence of hepatitis C in this high-risk population of injection drug use individuals, there was actually no difference in incidence of acute hepatitis C. What is interesting is that those who were vaccinated had lower HCV RNA levels when they developed an infection as those who received placebo. But I'm not sure that means anything because we know this virus is not necessarily cytopathic. I'm sorry. Oops. Yeah, sorry. And I'm not sure what a low level of viremia would mean in the vaccine response. So again, another failure of a vaccine attempt in hepatitis C. Now, few presentations were made on HCV treatment. We recognize that we've made a lot of advance in hepatitis C therapy, and that we're not going to see any more new drugs come out for hepatitis C. But there has been some effort to try and expand on the indication, fine-tune the treatment regimen. So this is use of glecaprevir and pibrentasvir in children aged 3 to 12 years. There are 81 children enrolled, all genotypes 1 through 6. The dose of glecaprevir and pibrentasvir based on their age, 9 to 12 at certain dose, those between 6 and 9 years at certain dose, and those between 3 and 6 at certain dose. And the bottom line is it worked well and had a high SVR rates of 96%, and this was given for 8 weeks. So this combination might have an indication in children, and it should have an indication in children. This is, again, a study in children with the other combination of sofosbuvir and velpatasvir. And again, the dose varied based on the age of the children. 6 to 11, it was 200 plus 50 milligrams of sofosbuvir and velpatasvir for 12 weeks. And those children between the ages of 12 and 17 received 400 and 100 milligrams. And again, you see high sustained response rates. So this might be a combination that that could be used for children. So this is these are two combinations that are likely to become available for use in children. Now, this is data on 8 weeks of glecaprevir and pibrentasvir in treatment-naive patients with hepatitis C and compensated cirrhosis. They had all genotype patients, and you can see here with 8 weeks of therapy in compensated cirrhosis, they had high response rates, except in genotype 3, there was a slightly low response rate, yet the response rates were over 95%. This is per protocol population and intent to treat population. So this, again, offers you all an opportunity to use just 8 weeks of therapy, regardless of the stage of fibrosis, and you can treat compensated cirrhotics with 8-week regimen. Now, what about those who have failed NS5A inhibitor containing regimen? This is from an Italian cohort called the ViroNet-C cohort, and looked at individuals who received NS5A containing regimen and failed. And there were 444 failures to different NS5A containing regimens. About 20% failed without any resistance-associated substitutions. And a good number had NS5A resistance-associated substitutions before treatment, and about 30% had multi-class resistance. Well, they were treated with various regimens, but I want to make sure while SVR rate is quoted as 100% in these patients, there are very few patients who received this regimen of GP plus ribavirin. Most received, rightly so, sofosbuvir, velpatasvir, and voxiloprevir, plus or minus ribavirin, and they had very high response rates. While the numbers are different, those who received ribavirin were 15, and they had 100% SVR rate. Those who did not receive ribavirin in this combination, there were 70 patients, and the SVR rate was 90%. So the conclusion was that you see NS5A resistance-associated substitutions in NS5A failing patients. SVR after resistance-guided retreatment was high, although I'm not sure it was actually guided by presence or absence of RASes. Most people were treated with the appropriate regimen. But they also concluded that resistance test after failure may be useful to optimize retreatment strategies, but I really didn't see any data on the pattern of resistance when they presented this paper. Now, this is not new knowledge. Achieving SVR, there's a low rate of liver-related mortality. This is a VA database primarily looking at those who were treated with pegylated interferon ribavirin. Those who achieved SVR had a lower liver-related mortality. And this is another abstract or a paper that looked at impact of SVR on extrahepatic outcomes, looked at acute coronary syndrome, end-stage renal disease, ischemic stroke, and clearly those who achieved SVR either with DA or interferon-based therapy, they had a lower rate of these events compared to those who are untreated or those who did not achieve SVR. Oh, this is an interesting abstract. I picked this one because at the Young Investigators meeting, there was a young investigator who presented a very provocative observation from his center, where it suggested that oral DA therapy may adversely impact HCC recurrence. Where Anna and I talked about it, and we really said we should really be looking at liver-related mortality rather just than recurrence. So this was a propensity score match study from 8 study sites, 2 were in US and 6 in Asia. Bottom line is those who achieved SVR, this is patients who had hepatocellular carcinoma in the context of hepatitis C infection, they had better survival and lower liver-related mortality. And this was a rather important observation. Lastly, I want to talk about something that's very exciting, something that's evolving in the Western world, and something that we at our center are heavily involved in, and this is to look at use of hepatitis C positive donors in solid organ transplantation. Given the unfortunate epidemic of opioid abuse and mortality, we are being offered a fair number of hepatitis C infected organs from young individuals. And the question is how to use them. And we started off with using hepatitis C infected kidneys in uninfected recipients. And now that paradigm has moved to involve heart transplant, lung transplant, and liver transplant. And there's any amount of data out there, although they're small studies, where this strategy has worked very well. Obviously, we want to be very careful because we cannot afford to fail in treating HCV after deliberately infecting them, because that would not just look good. And so we need to we ensure that these patients are treated appropriately at an early time and that we have a rescue therapy in place. So first point I want to make is based on this presentation, and something that we've also observed is that if you use a hepatitis C positive organ in a negative recipient, they become viremic very early on, as early as day 2 or 3, and they have high level of virus. This is something that was presented in kidney transplant recipients. So to that end, the Canadian folks, and this has been done by others as well, have gone into a preemptive strategy when they use hepatitis C positive organs, and also looked at short course treatment of 7 days rather than the standard duration of therapy. This is sort of very interesting. They used ezetimibe, which you may or may not know is a drug that drops LDL. And one thought is that hepatitis C entry is facilitated through LDL receptor. So they thought that maybe it would block entry of hepatitis C into the hepatocyte. So they used ezetimibe and a 7-day course of hepatitis C therapy, which is glecaprevir and pibrentasvir. And they used the strategy in 25 patients. There were no virologic failures. The SVR 12 was seen in 18, and 6 had reached, 7 had reached SVR 6 stage. Remember, there's only 1 week of therapy, and they had SVR. So basically, they're suggesting that maybe we could shorten the duration of treatment when you use the strategy, and not necessarily go with either 8 or 12 weeks. So that's an interesting observation. This is the liver transplant population. It's a retrospective study. 24 HCV seropositive donors were used in seronegative liver transplant recipients. 10 were NAT negative, that means they were antibody positive, NAT negative. 14 were NAT positive, and they intervened quite early on, before day 7, and they all achieved SVR. So this again is quite reassuring. They used GP in 12, soft-well in 12, soft ledipasvir with or without ribavirin in some of the patients. And then this is a shorter duration strategy of using GP for just, I believe, 8 weeks. They gave, no, I'm sorry, 3 hours. No, actually, yeah, 8 weeks, and then they achieved a high SVR rate in those who were infected with a positive kidney. So to summarize, global HCV eradication strategy is working in some countries, apart from Iceland. It's working very well in Australia, but there's still huge challenges in other parts of the world. It's feasible to treat persons with injection drug use history. Adherence is a challenge. Yet another attempt at HCV vaccine development has failed. Now we have pangenotypic regimens available for children. Then you can use an 8-week pangenotypic regimen for treatment-naive patients with compensated cirrhosis. 6 weeks of therapy did not work in acute hepatitis C infection. Need longer than 6 weeks, 8 to 12 weeks perhaps. And then we all know this, there are multiple benefits of SVR, but more importantly, the one abstract that showed improved survival after treating HCV in those with hepatocellular carcinoma was quite interesting and encouraging. And then post-transplant, now the strategy is to look at varying duration of therapy as short as 7 days to at most 4 weeks of therapy. Traditionally, we've done the 12 weeks of therapy in these patients, but maybe there is room to cut the duration of therapy in the transplant recipients or deliberately infected. So with that, I'll stop, and I'd like to acknowledge a couple of people. Mark Ganny, who actually did the debrief at AASLD, he lent some of his material, and Mark Sulkowski, and some of the presenters were kind enough to give their presentations as well. Thanks very much.